Welcome all to the today's class. So we begin with next topic in the endocrinology, that is the sex hormone. Okay, so here we have mainly the estrogen, androgen, progesterone that we are going to discuss. Okay, so what happens? We have secreted by the gonads, which are these hormones. Sex hormones are secreted by the gonads, and they are under the control of the FSH and LH. Okay, and the hormones are the estrogen, androgen, and the progesterone. Please remember the carbon number of carbon atoms also. Okay, so estrogen will have it's a carbon 18 molecule. Okay, the source is ovary. Androgen is a 19 carbon compound. The source is ovary as well as testes, and progesterone is again a 21 carbon compound. It is present in the ovary. Okay, so carbon 18 is estrogen, carbon 19 is androgen, and C21 compound is a progesterone. Okay, now coming to the ovarian hormones. Okay, basically you should remember this two cell theory. Okay, what is this two cell theory? You have two types of cell, that is the theca cells and the granulosa cells. They produce two hormones. Okay, so these theca cells, they will produce the androgen, which is a C19 molecule. Okay, so it has got a 19 carbon. These theca cells will produce androgens. This granulosa cell will convert it to estrogens via aromatase. So there are two cells, theca cells producing the androgen, which is a C19 compound, while the granulosa cell will convert this to the estrogen via aromatase pathway. Okay, this aromatization, there is aromatization of ring A and loss of C19 methyl group, leading forming C18 molecule. Okay, so coming to the estrogen. Estrogen is also of three types. This also you remember, they can ask you in the SBA. So one is a estradiol, that is E2. Second is estrone, that is E1, and estradiol, that is E3. Estradiol, that is the E2, is the most active. From SBA point of view, you remember which is the most active, that is the estradiol. Okay, so when the patient is young, reproductive, okay, you get a estradiol. Okay, in young reproductive, you need a think of a couple. Basically in young reproductive period, you think of a couple, so it is di. Okay, so that is why you take the young reproductive age group di. Okay, so estradiol is the most active. If it becomes estrone towards menopausal phase, okay, so there is no couple, it is alone. Okay, one. Okay, so in menopausal it will become estrone. So which is more predominant in the menopause? It is estrone, it is less active. Then estriol is the weak or the inactive. This is present in the pregnancy. Okay, so estriol, how many trimesters are there in pregnancy? There are 3 trimesters. So you remember tri, estriol. Okay, 3 trimesters, it is present in the pregnancy, that is weak or inactive. Okay, so estradiol is converted into estrone in the liver. Estrone is further converted into estriol, that is the inactive form. Okay, so you will remember in young reproductive age group, estradiol. Menopause, it is estrone. Pregnancy, it is estriol, and active is estradiol. Okay, now this is bound to the SHBG, that is sex hormone binding globulin. So this estrogen will bind to the SHBG. So mechanism of action, the steroid hormone, it is a steroid hormone. So steroid hormone, normal general mechanism we have already seen. Where is the receptor? It is the intracellular receptors. So it has got two receptors, estrogen receptor alpha and estrogen receptor beta. So it will enter into the cell, bind with the receptor, then complex will enter into the nucleus. That will lead to the gene transcription. Via mRNA, there will be protein synthesis. Okay, very simple now. So what are the functions of estrogen? In the uterus, it causes endometrial proliferation. In the breast, it causes ductal growth. In the bone, it maintains the bone density. And for progesterone, it increases the progesterone receptors also. Okay. Now, what are the drugs related to this estrogen activity? Commonly used is a clomiphene. So this has got an anti-estrogenic activity. So it blocks the estrogen receptors at the level of the hypothalamus. That is how it increases the FSH level, and that is why there is an increased follicular growth. So it leads to the ovulation induction. Okay, so clomiphene citrate, it will block the estrogen receptor. This mechanism from pharmacology point of view also, this can be asked as a SBA. Okay, clomiphene will block the estrogen receptors in the hypothalamus, and it will release the FSH that will lead to the ovulation induction. Another is a tamoxifen. It causes estrogen receptor antagonist. It blocks the estrogen receptor. It is used in the treatment of breast cancer. Then you have selective estrogen receptor modulators, SERMs. Okay, that is a selective receptor action that is very tissue specific effect. Okay, now regulation of ovarian hormones. So menstrual cycle hormonal control. What happens in the follicular phase? Initially, it is FSH that will lead to the follicular maturation. So before ovulation, there is an increase in estrogen level. This increased estrogen level, there is a before the ovulation, there is a peak of this estrogen. That peak of the estrogen is 24 hours before the LH surge. So this peak of the estrogen will further lead to the LH peak that is around 16 hours before the ovulation. Okay, so this is 16 hours before the ovulation, there is a LH surge, and 24 hours before the LH surge, there is a estrogen peak. Okay, so I hope you are getting this. First, there will be estrogen peak. After 24 hours, there will be LH surge, and after 16 hours of LH surge, there will be ovulation. Okay, so this LH peak will cause ovulation and the corpus luteum formation. Once the corpus luteum is formed, then you will get the progesterone. Okay, this progesterone will have the effect on the endometrium. It will cause secretory changes. So there will be secretory phase, and it prepares the endometrium for the implantation. So if pregnancy happens, the SCG will replace the LH from the cytotrophoblast. And this all we have seen in the general embryology. Okay, so it is detectable 5 to 7 days after the miss period. If there is no pregnancy, then what will happen? There will be decrease in estrogen and progesterone level that will lead to the endometrial shedding. That is the menstruation. Okay, so from examination point of view, it is the high estrogen level that suppresses the LH that gives the contraceptive basis. Okay, so what we have seen here, this high estrogen level momentarily, which is very picked, that will cause LH surge. But when it remains persistently high, that will cause suppression of the LH. So that is what is the action which you are getting in the oral contraceptive pills. Okay, so high estrogen will suppress LH that has the contraceptive basis. Then progesterone prepares the uterus for the implantation. Okay, now coming to the testicular hormones. So testosterone is the main male hormone. It is produced by the Leydig cells. It is stimulated by the LH. Okay, so it is stimulated by the LH. So LH is the hormone that stimulates the Leydig cell, which secretes the testosterone, while FSH will act on the Sertoli cell. And what is the function of the Sertoli cell? It produces the androgen binding protein. It maintains the high local testosterone, and it is essential for spermatogenesis. Okay, then what is the feedback mechanism? Now this testosterone will give the feedback at hypothalamic level that will lead to the decrease in GnRH, that will lead to the decrease in release of LH from the pituitary. Okay, and what happens in the hypogonadism? There will be increased LH levels, but pituitary is acting, so pituitary will produce more and more LH when the gonads are hypoactive. Okay, so in hypogonadism, there will be increased LH, while in azoospermia, there will be increased FSH. Okay. So what are the actions of androgens? So in the reproductive system, it will lead to the spermatogenesis. In the muscle, it will have anabolic effect. In the bone, it will cause growth. In the prostate, it will cause hypertrophy. Okay. Now, let's see something about dihydrotestosterone, that is DHT. Okay, this DHT, that is dihydrotestosterone, is formed from the testosterone via 5-alpha reductase. Now, what does this DHT does? This DHT leads to the prostatic growth, and it also leads to the formation of external genitalia. Okay, so when there is a benign prostatic hyperplasia, there is an increase in levels of DHT. So this increased DHT you can use by this alpha reductase inhibitor. The treatment is a finasteride. So you in BPH you use finasteride, which is a 5-alpha reductase inhibitor. So that will reduce the conversion of testosterone to dihydrotestosterone. Okay, so that is what is about the sex hormones. Okay, so we have few questions about the sex hormones. Doctor, can you please read the questions?
Yes, sir. What is the most biologically active estrogen? Sir, option C, estradiol.
Estradiol, correct. Next.
In ovarian steroidogenesis, androgens are produced by granulosa cells, theca cells. So option B, theca cells.